Thank you for the invitations. My topics today is focal seizures can be subtle and commonly missed. This is the approach to seizures whereby we will talk about whether an event is epileptic or non-epileptic, focal or generalized, and then we will determine the etiology and syndromes. Today, my focus will be on focal seizures. In 2017, seizures were classified as follows: focal onset, generalized onset, and unknown onset. Most aura are non-motor onsets, whereas if someone has a motor phenomena, we should ask whether it's focal or asymmetrical. Automatism and hyperkinetic seizures are usually focal onset. This is a case whereby a 45-year-old man with seizures presented as aura burning sensation in the epigastric regions, blank staring, oral chewing movement, which we usually call oral automatisms, head deviations to the left and left arm dystonia, and occasionally with fall and tonic-clonic seizures. So what type of seizures does this man have? He is having focal seizures. It's important to classify seizures into focal and generalized because the etiology are not the same, medication of choice, prognosis, and the options for epilepsy surgery are not the same for both focal and generalized seizures. However, in emergency department or in medical clinic, we are often seeing patients with GTC, or the short form for generalized tonic-clonic seizures. But not all GTCs have a generalized onset. Some of them, in fact, have a focal onset. So these are the diagnostic tips towards partial or focal seizures. Clinically, we may look for focal neurological signs. There may be aura. There may be asymmetry in presentations. There may be post-ictal focal phenomena, such as paralysis dysphasia, or the neuroimaging may have focal abnormalities like stroke, tumor, trauma. Age more than 20 are usually having a focal onset because most generalized epilepsy has an onset before age of 20 years old. However, it's also important to describe the seizure in details, which was usually classified as pre-ictal, which we call aura, ictal, and post-ictal. The aura can be divided into sensory, psychic, auditory, and visual, which is corresponding to different lobes in the brain. I'd like to explain a little bit more on the psychic aura. Fear and déjà vu are very common aura in temporal lobe epilepsy. And sometimes patients may have epigastric aura, which is an epigastric sensation ascending from the stomach to the throat. This is different from those with peptic ulcer disease because epigastric aura is usually very short. Gastatory aura is an abnormal taste that was experienced by the patients. In terms of ictal motor phenomena, we should ask the witness about what happened to the head, eyes, face, mouth, limbs, and body. Head version is a very unique features whereby the head is forcefully turned at least more than 45 degrees and sustained, rather than just looking or head turning to the left and right side, which is called deviations. I would also want to highlight about the limbs movement. Under the limb movements, patients may have asymmetrical tonic posturing, whereby one limb may be flexed and another may be extended. This is called asymmetric tonic posturing. Hypermotor and automatism I will describe a bit more later. This is features of temporal lobe seizure, whereby this patient has aura of fear. He also have lip smacking, which is indicating oral automatism. And look at the hand and legs, which is an automatic movement, especially the left hand here. These are consistent with temporal lobe seizure or temporal lobe epilepsy, commonly seen in those with mesial temporal lesions like mesial temporal sclerosis. So, besides the aura of fear, deja vu, olfactory, gustatory, or epigastric aura are also common aura in temporal lobe. Sometimes they may have blank staring, oral automatism, and contralateral dystonia, ipsilateral automatisms. And most often they have a memory loss of what has happened to them. Whereas the picture over the right lower end showing the right hand in a dystonic posturing, which indicate the lesions is on the left side. Whereas frontal lobes in semiology are more variable. Firstly, in the primary motor area, you may see ictal tonic-clonic seizure, as in this video. The left face is pulling, which is consistent with left face tonic seizure. Sometimes the head is forcefully turned, as I mentioned. This is called version or versive seizures. As in this picture shown, the head is turned forcefully to the left side. Some patients have very aggressive hypermotor seizure, like in this video, which is very violent and usually brief, and they are stereotypic, occur mostly in sleep. The hypermotor seizures are usually happen with a lesion from the anterior part of the frontal lobe, like orbitofrontal regions. Some of the seizures are originated from the medial aspect of the frontal lobe, like supplementary motor area, as shown in this picture, whereby the right hand is extended and the left hand is flexed. This is called asymmetric tonic seizure or asymmetric tonic posturing. In the old days, we call this fencing posture or figure of four. Sometimes the seizures spread from one to another regions or have a mixture of these features. Because of the complexity, we have developed a focal seizure screening tool, which was published last year. This tool is simple and rapid to be administered within 1 or 2 minutes. It was derived from 33 questions asking various symptoms of a seizure in more than 100 patients. And these are the common features that can identify and reported by patients or eyewitness. These include aura, unilateral motor phenomena, and oral automatisms. On the left are questions that was given to the patients and can be answered by anyone who witnessed the seizure or the patient themselves, if they are aware. Whereas on the right are a confirmatory checking by the clinicians on the terms, the items stated on the left. Every column is given a score of 1 with a total of 3. So if a patient have any of these deja vu, fear, or epigastric aura, they will be given a score of 1. This scales is easy to be applied because it has been answered by more than 100 patients on these items. However, be aware, sometimes the patients may have abdominal discomforts, which is due to peptic ulcer disease, and we need to confirm whether they are truly epigastric aura or they are in fact a dyspepsia felt in abdominal disorders. The difference is that epigastric aura is usually very short, lasting seconds to minutes and preceded the seizure. Secondly, on unilateral motor phenomena, some of the patients may answer yes, but instead they are having bilateral tonic-clonic seizure. We need to confirm because patient may not be aware or miss the statement asking that this is about one side of the body. So if the patient is having bilateral tonic or clonic seizures and take one, then we should correct the score. Oral automatism can be also misunderstood sometimes, but uncommon, whereby some patients with tongue biting or teeth biting, they may take yes, but in fact, these are not oral automatism. So a double check or confirmations by the clinicians over the right side is very important to make sure we have score it correctly. These scales have a high specificity if the score is more than 2. However, if we score more than 1, it has a high sensitivity to suggest these are likely focal seizures. How about management? I would focus mainly on the first line anti-epileptic seizures. However, in the management in epilepsy, the first thing is to decide whether to start treatment or not, then only followed by choosing the right anti-seizure or anti-epileptic drugs. I will only briefly touch about newer anti-seizure medications and epilepsy surgery. So this is similar patients with a 40-year-old man with temporal lobe seizure presented with oral automatism and left dystonia. So the diagnosis is right temporal lobe epilepsy because of oral automatism and dystonia. And I say right side is because he has left dystonia, which is contralateral. So which anti-epileptic drugs would you consider? So these are the few choices that you may want to consider, and you should think about the answers in your mind. However, the choice of drugs can be based on a few key or simple rules. The first one is evidence. This is a non-inferiority charts comparing two medications. And for focal or partial onset seizures, there are 4 level A drugs, which include carbamazepine, levetiracetam, phenytoin, and zonisamide. A simple rule number 2 is seizure types. As you can see on the right side, for focal seizure, most of the currently available medications can be used for focal onset seizures. However, just bear in mind, sodium valproate or lamotrigine may have a less effectiveness in focal seizure and require a higher dose. Third is follow the guidelines. This is a MSN consensus guideline in 2017, which suggests carbamazepine, lamotrigine, levetiracetam, oxcarbazepine, sodium valproate, and zonisamide for focal seizure, but sodium valproate is with an asterisk, indicating a higher dose is needed. And rule number 4 is to keep it simple. For generalized epilepsy, I would usually recommend sodium valproate unless it's contraindicated, especially in childbearing women who has married or has a plan to get pregnant. For focal epilepsy, it will be carbamazepine, and I rarely use phenytoin nowadays. If these are not indicated, contraindicated, or not effective, then we can consider lamotrigine or levetiracetam for both generalized and focal epilepsy. However, for carbamazepine, there is a small risk of developing Stevens-Johnson syndrome. The patient may have rash, itchiness, or mouth ulcers, and the patient need to stop carbamazepine immediately. In the past, when we give carbamazepine, we always remind patients about these symptoms and warn them to stop whenever these symptoms develop. Whereas nowadays, we have a screening test, which is called HLA-B1502. This is strongly correlated with carbamazepine developed Stevens-Johnson syndrome, or TEN. This is also highly prevalent in Malaysia, and therefore it's recommended that whenever we want to start carbamazepine, you should consider screening HLA-B 1502. This is what my current practice. So if a patient came to my clinic and suspected to have focal seizure based on the symptoms, I would send their HLA-B 1502 on the first clinic consultations. When the patient came back for the second clinic consultations, and if the HLA-B is negative, I will start carbamazepine. However, if this is not available in your hospital, it is acceptable to give carbamazepine but warn the patients and remember to start a small dose in the beginning and titrate up slowly. The dose I usually use is 100 milligram carbamazepine on the starting and titrate to 100 BD either after 1 to 2 weeks later. And always warn the patient if there is a rash, itchiness, or mouth ulcers, they should stop carbamazepine. What is next if carbamazepine failed or contraindicated? For example, patient is HLA-B 1502 positive. These are the options I normally consider. Levetiracetam is preferred because it has high efficacy and better tolerable with less side effects. However, when cost is a concern, lamotrigine is a good option, which we should titrate slowly from a small dose and titrate every 2 weeks. The low dose is less effective, but when it is titrated to a higher dose, it is usually effective as levetiracetam. And more importantly, is cheaper. Topiramate and perampanel is considered when we are desperate or the seizure is very frequent or when they are refractory to many other drugs. So what can we do when someone has refractory epilepsy? This man has seizure presented with lip smacking, right hand automatism, and left hand dystonia. So this is a patient with temporal lobe epilepsy, refractory to carbamazepine 400 milligram BD. We can push up the dose or try other medications, and ultimately, the patient has failed all the other anti-seizure medications. He had a MRI which show a right side mesial temporal sclerosis. As shown in the arrow, there are T2 signal change on the left, and there are volume loss on the right MRI. Mesial temporal sclerosis is a condition which is slightly refractory to treatment, but have a good success rate with surgery. The EEG show right temporal discharges, which is concordant, and for this patient, surgical option is available. Surgery can be a cure for patients if we identify the lesions causing the seizure with proper pre-surgical evaluations, and therefore consider referring patients with focal seizure when it is uncontrolled with at least 2 seizure medications, or the focality is uncertain even if the MRI is normal. This is not an exclusion criteria. This is our data showing that 80% of mesial temporal sclerosis achieve seizure freedom. Those with lesions, 60% achieve good outcome, and even those with normal MRI and undergone invasive EEG, 50% of them has achieved seizure freedom despite failed many anti-seizure medications. This is our latest progress whereby we had started stereo EEG monitoring, and our first case was monitored in December 2019. As you can see in the picture, a burr hole was made. The electrodes was inserted deep into the brain, as deep as insula, as deep as hippocampus, as well as cingulate, to monitor the seizure activities. And this is very specific and sensitive in detecting ictal or seizure onsets. This is our UMMC comprehensive epilepsy unit, including the adult and pediatrics group, as well as our pathologists, surgeons, and radiologists. In conclusions, symptoms in focal seizures can be subtle or missed. GDC can have a focal onset. Carbamazepine is a first-line treatment. Even without HLA-B1502 screening, we should consider carbamazepine first. If refractory to anti-seizure medications, refer to pre-surgical evaluations. And lastly, remember our focal seizure screening tools, which include aura, focal motor presentations, and automatism. Thank you.